Hi, and in our next section here of endocrinology, in section 10, we have chapter 2. It is a very short and pertinent chapter on the relationship between the hypothalamus and the pituitary. So it is indispensable and very straightforward. You're going to like it. You're going to like it. Now, the main thing is that all the hormones that come out of the hypothalamus are all peptides. Now, the slide here, you'll see, says the phrase, they're all water-soluble. Now, that's another way of saying they're all peptides. Okay. The brain doesn't make steroid hormones. Fine. Fine. Brain doesn't make steroid hormones. Okay. Now, since they're all water-soluble, they get synthesized in those cell bodies and then packaged and stored in vesicles. So since they're water-soluble, they can be stored and packaged in vesicles. You can't package things in vesicles that are made out of lipids or lipid-soluble because they will walk right through the vesicle. Now, they come down on neurons, axons, from the hypothalamus and into our pituitary, and we're good. Now, the pituitary dangles generally right dead center through my nose and in here. And if you put these two things in a point, where they meet, right dead center in there, in the center of the brain, that's where the pituitary is. That's why, you ready? A patient comes in with acromegaly, big nose, big toes, big hat, big shoe, and really puts the U in the ugly. So, acromegaly, what's the best initial therapy for acromegaly? Transsphenoidal surgery. Transsphenoidal surgery. Let's go right up your nose. Boop! Right up your nose. Why? Because that's where the pituitary is. Right up the cribriform plate in the top of your nose. That's the same thing as saying base of the skull, sella turcica, cribriform plate, transsphenoidal. They all say the same thing. There. Now, the optic chiasm, fundamentally where the nerves meet that comes out of the optic nerves, is just a few millimeters above that. And that's why it needs a really big pituitary tumor to press on it. But pituitary tumors can press on it if they grow for a long period of time. Extra bonus question. Who comes to attention more with visual disturbance and pituitary tumors? Women or men? Who comes more often with visual disturbance from pressure on the optic chiasm? Is it the woman or the man? Well, who comes to attention sooner, a woman or a man, for pituitary tumors? Who'll come to the doctor sooner? The woman. The man comes later. The tumor is bigger. Now, let's see different ways of saying the same thing. Man comes later is the same thing as saying tumor bigger. Is the same thing men present more often with visual disturbance. Man, visual, later, bigger. Well, I see them as saying one thing. Man, come later with a bigger tumor, more visual problems. Woman, earlier, smaller, less visual problems. Why do women come sooner? Well, let's put it this way. Men present most often with erectile dysfunction. Women present with pituitary tumor. What's the most common presentation? Prolactinoma. Galactorrhea, and most importantly, missing a period. Who presents sooner? Let's see. Man with erectile dysfunction, pituitary tumor. Woman with amenorrhea and missing a period. Who's most likely to come to the doctor? Let's think. Man with erectile dysfunction, woman with missing a period. Man, just got erectile dysfunction for the last 2 weeks. Woman missing her period for 2 weeks. Man, run to the doctor. Hi, listen, I gotta see you right away. I haven't had an erection in 2 weeks. Hurry. I don't think so. Doesn't catch attention. People don't run for that. Ooh, bachelorette party and 2 weeks later, skipping period. I think that would catch your attention. So who come to attention sooner? The man with the erectile dysfunction for 3 weeks or the woman that 3 weeks after the bachelorette party is skipping her period. Now you know why they come earlier. Women present earlier because a skipped period really catches attention. A skipped erection is unfortunate, but it's not announced. Men come later, bigger, visual. Women, earlier, smaller, and juicier, galactorrhea. Now, general features of our hypothalamic anterior pituitary system. Now, hormone release is pulsatile, I see. It's up and down, level, pulsatile. They're all pulsatile except, yes, thyroxine, exactly. And that's a good thing too, because you know what? I want constant temperature, right? I don't want to have to go out and sun myself on a rock in the morning like a lizard. I don't want to have to be like a snake that has to go lie in the sun to get warmed up. Ah, yes. Isn't it awfully nice to be a homeotherm? Yes, it is. That's one of the great beauties of being a homeotherm. It also gives me the opportunity to look down on all those poikilotherms there. Hey, poikilotherm, if you had my thyroid, you wouldn't be so cold. Ha! It's good to be a homeotherm. Also, biological processes. If your temperature goes 3 points above normal, you're not going to think straight. If your temperature goes 3 or 4 points below normal, you're not going to think straight. Temperatures of the brain above the 103.4, you're confused. 105 you see is. Temperatures 3, 4, 5 points below normal, when your body temperature goes down to 93, 92, you're going to have a coma practically. You need nice constant biological temperatures. That's just the way it is. Remember, thyroid hormone is constant because thyroid hormone has a receptor that maintains the sodium potassium ATPase in like every cell in the body, with the exception of brain and gonads. Brain and gonads. Pulsatile release prevents down regulation. Down regulation happens when the levels are too high, and then the receptors become insensitive and go away. What's the difference between down regulation and tissue resistance? What's the difference between down regulation and tissue resistance? And the answer is nothing. They're the same thing. Down regulation, loss of receptors. Tissue resistance is related to loss of receptors. Down regulation is tissue resistance. Same thing. The level is up all the time of the hormone, the receptors downregulate. You wear too much perfume, too much all the time, I can't smell it anymore. You send me the same poem over and over and over again, after a while I don't read it. It's the same with any form of stimulation. In a way, you could say it's good that happens sometimes, downregulation. It's kind of like getting used to annoying things. Look on the bright side. You can get used to annoying things too. You downregulate. Here, GnRH will cause a decrease in the release of FSH and LH, but only when it's been given for a while. A man comes with metastatic prostate cancer to the spine. He is given GnRH agonists, goserelin leuprolide, goserelin leuprolide. Next, 3 days later, he is paralyzed in the lower extremities. What is most likely to have caused this? He's paralyzed in the lower extremities. What's most likely to have caused this? And the answer is momentary burst up of FSH and LH. Momentary burst up of FSH and LH. It's only later, after a while, that the FSH and LH will go down. But remember, it's a burst up of FSH and LH, and the most frequently asked question on this subject is, do you understand that if a guy's got a metastasis of prostate cancer pressing on his spine, the GnRH agonist at the beginning will make the cancer bigger, and then later it suppresses it. That's why you have to use another substance first, a hormone blocker first, at the testosterone blocker first. You ready? A man comes to the office for metastatic prostate cancer. He is about to undergo an infusion of GnRH agonists, goserelin leuprolide, goserelin leuprolide. Which of the following medications must you use first? The answer is flutamide, testosterone receptor blocker. Flutamide is given and prevents the growth of the tumor. Flutamide is given and prevents the growth of the tumor. What's the following is the mechanism? Testosterone receptor blocker. Flutamide, testosterone receptor blocker. Blocks the burst up. Remember, downregulation needs time. Doesn't happen instantly. Downregulation needs time. Next slide. Oh, here's our picture of, this is our diagram of the hypothalamus, and here's where things are made. Here things are made. Here's where things are made. And it goes, wee, woohoo. Isn't that cute? Things are made, and then they get stored down there in the pituitary. Yes, I understand. This could be almost anything here. This looks like, it could be a schematic of almost everything. It looks like GPS in a way. So just saying, in a picture, the same thing, that things are made up in the hypothalamus, they're made up here in the hypothalamus, and they get stored down here in vesicles. And it also means that if you cut this, if you get this cut, if you cut this with trauma or tumors or any other form of action where you cut that stalk, you can't get the hormones into the posterior pituitary. If you cut that stalk, again, let's look over here, and you cut that stalk, you can't get the hormones into the pituitary. That is the single most frequently asked pituitary hypothalamic question. So even though you may know it, let's say it here so that we all say the right thing we have to, which is a man has a motor vehicle accident, a man has some sort of head trauma, and his stalk is cut. Which of the following hormones will rise? And only one rises, and the one that rises is prolactin. Prolactin goes up. Hey, are you against lactation? No, I'm for lactation. Oh, you're pro-lactation. Prolactin. Well, I guess so. The only one that goes up is prolactin. Why? Because it's under tonic inhibitory control. It's under tonic inhibitory control. You cut the stalk, prolactin goes up. You cut the stalk, prolactin goes up. Because it's the only one for which the inhibitor is secreted all the time. Why? Why do I want to inhibit it all the time? I want it inhibited because I don't need prolactin to make my breasts big now. I don't need prolactin to make my breast tissue large now. Is the baby? Hey, where's the baby? If I got a baby, I want my breast tissue big. But if there's no baby, I don't want my breast tissue big. The same way I don't want to serve lunch now if I'm here and I'm not going to lunch in 4 hours. Hey, we put a glass of milk out for you. Hey, why put a glass of milk out now? It's going to get spoiled. Why waste the food and it's only going to go rotten? Same with prolactin. We keep it inhibited all the time because there's no baby there to have that milk. The same way you don't put out dinner now when you're not going home for 8 hours. Same idea. Fresh direct. Next slide. Oh, this is a very important slide. It basically says the specificity. Thyrotropin releasing hormone has the thyrotrope, so it makes thyroid stimulating hormone, which makes T4. Okay, cool. Wow. And thyroxine receptor on every cell in the body, with the exception of neural tissue and the uterus. Now, isn't that amazing? That means the entire body can be controlled. Virtually every cell, every sodium, potassium, ATPase, every biological furnace. How come you're not room temperature? Because you have mitochondria cracking the ATP, creating heat. Wow, the very furnaces of every cell in the body controlled by thyroid hormone, all from one hormone called thyrotropin releasing hormone out of the pituitary, out of the hypothalamus. Interestingly enough, albumin is a huge molecule, but controls nothing. Thyrotropin releasing hormone is 3 amino acids, yet will control from the hypothalamus the metabolic rate and activity of virtually every cell in the body, with 3 amino acids coming out of your hypothalamus. Wow. It's like a great Sufi master, Jalaluddin Rumi. Rumi goes, oh, look, my heart is so small. How can this great love be inside of me? And Rumi says, look at your eyes. They are small, but they see enormous things. Look at the thyrotropin releasing hormone. It is small, 3 amino acids, but it controls enormous things. This is a slide just to show the specificity. Corticotropin-releasing hormone, corticotropin-releasing hormone, making corticotrophs, make ACTH. What's interesting about it is to show you how much of the pituitary is devoted to growth hormone. See how much pituitary is devoted to growth hormone? Enormous amount. Now, look here, this is our last point on this slide. You see how somatostatin has a negative control on growth hormone? Somatostatin is a negative control. Well, somatostatin, inhibits everything. Somatostatin doesn't stimulate anything. If it says stimulate, somatostatin's not the answer. Somatostatin inhibits everything. It stimulates nothing. Somatostatin never met a hormone it didn't like to inhibit. Well, if prolactin inhibitory factor inhibits prolactin, and somatostatin inhibits growth hormone, releasing growth hormone, how come it is that when you cut the stalk, that the growth hormone level doesn't go up? And the answer is, the major stimulant is the releasing hormone. Somatostatin is minor, and that's why only prolactin goes up. Well, our next slide is disorders of the hypothalamic pituitary axis. Hypopituitarism. 1, you could stroke out the pituitary. You could infect it out. Very rare. You could trauma and beat it out. You could cancer and displace it. You could squish it. It's like making chicken. You can fry it, boil it, bread it, fricassee it, lemon, pituitary, pituitary cordon bleu. So any way you want, you can destroy it here. You could tumor it out, freeze it out, burn it out, cut it out, chop it out, come on down here to pituitary is ours, yeah. So the thing is that when you have a pituitary tumor, remember that when the tumor enlarges, it displaces and compresses the other tissues, the other cells. So nothing has to happen to them except it has to be compressed and it cuts off its blood supply, and that's it. Now, it is very hard to have isolated pituitary deficiencies, though. Here it says isolated deficiency, growth hormone. Very hard to have an isolated pituitary deficiency of just one of the hormones. Very rare. Because why is it that you'd get destruction of just one little piece of the pituitary hormones? That's why most people have hypothyroidism. Have hypothyroidism at the basis of their thyroid burns out. To just have an isolated low missing the TSH, very rare. Isolated low just missing the ACTH, very rare. Almost all hypoadrenalism is from adrenal target organ deficiencies. Target organs are the way to be deficient. Very rare to be isolated single cell lines in the pituitary. Now, stimulation testing, this is a bit of a repeat of what we did before. I inject something that comes out of the hypothalamus, and I try and give my pituitary a kick and stimulate and see if it works. GnRH with LH and FSH, thyrotropin, releasing hormone assays. Using these releasing hormones as a means of diagnostic testing is very good in terms of physiology, however, rarely if actually ever done clinically. Next slide. Sheehan syndrome. Now, Americans generally don't like eponyms, eponymous names, naming something after someone, because you go, what's a Sheehan? But if you say pituitary infarction syndrome or pituitary apoplexy, oh, you go, right, well, I don't know what it is, but the pituitary is weak. That's why it is better in general for us to use terms, and as we shift over time. For instance, even in America, we don't say Lou Gehrig syndrome, we say amyotrophic lateral sclerosis. Because at least it gives some clarity and knowledge just from the name. Do you have Berger's disease? Well, I don't know, I have IgA nephropathy. You have Berger's, what is it? I don't know, I'm naked. Well, IgA nephropathy. Well, I don't know what it is, but I know that my kidneys suck and it's autoimmune and I got an IgA problem. So it is better to use a term that has actual medical meaning. Now, Sheehan syndrome means that in pregnancy, the pituitary enlarges. Okay, more blood supply. Your breasts enlarge, your pituitary enlarges, your plasma volume goes up by 50%. And then the problem is that after delivery, you have blood loss sometimes. See this one said with severe blood loss? And the problem is that of all places, your pituitary can selectively infarct off. Wow, of all the places. Panhypopituitarism. All of the cell lines. Next slide. Pituitary adenomas. Now remember that an adenoma is not necessarily a malignancy. An adenoma is not necessarily a malignancy. Matter of fact, most are not. No, when you say, what's an adenoma then? Is it's not normal? No. It's not hyperplasia? No. It's not dysplasia? No. It's not malignant, but it's not just hyperplasia either. It's like a personality disorder. What is it? Are you schizophrenic? No, but it's like a personality disorder. So it's not quite the same thing. So the thing is that pituitary adenomas, when they're really large, they compress the rest of the tissue. Now what's more common? Micro or macro adenomas? Micro is far more common. Well, it's understandable. You start out small, and then it gets larger. So what's more common? What's more common is small. Well, you go to certain countries and 50% of the population is under the age of 18. Whole countries are like that. 50% of the population. Why? Because smaller, younger, then they grow up later on. That's why there's more people alive on the planet now, today, 6 billion plus, than have been alive in total in the entire history of the world. Well, because they're smaller. Smaller is always more common. They could get bigger later on, but you got to start smaller. Microadenomas don't have, you see what it says, no panhypopit? No panhypopit because they're too small to compress the normal tissues. Macroadenomas, when they're really large, compress the normal tissues, can compress the optic chiasm. Now, usually benign means that they're not going to metastasize, and I'll tell you the other thing. Malignancies are not functional. The same way criminals don't pay their taxes. Criminals don't obey the rules. They don't pay their taxes. They aren't good citizens of the society. In the same way, malignancies are not good citizens of the body. They're not under normal suppression, and they don't make their normal hormone. That's why it's more often adenomas, because adenomas are functional. They make things that you can detect. This is a very big question here. You see this? Hyperprolactinemia, 60%. That is a massively important question, because if you said to me like this, hey, Conrad, hey, fishy, give me the bottom line. What's the one question? I don't want to learn all this. Give me one question about pituitary, and I'll learn it. Okay, you ready? Most common macro, most common microadenoma, prolactin. Erectile dysfunction in men, and galactorrhea, amenorrhea in women. Men who don't have erections and ejaculations, women who have too much breast flow. You get dry men and juicy women. Prolactinomas, most common. Now, let me make another little point here. I'm in live classes with a couple of thousand medical students and doctors a year. And when I ask them what they think the most common presentation of pituitary tumors is, 85% say bitemporal hemianopsia and headaches. About 85 years ago, Harvey Cushing invents neurosurgery. Harvey Cushing was the first major student, first resident of the great Sir William Osler, who started internships and residencies in this country. Osler, who says, happiness lies in the absorption in some vocation which satisfies the soul. Happiness lies in the absorption in some vocation which satisfies the soul. Cushing did a residency with him for 7 years. Cushing basically single-handedly invents neurosurgery. Cushing's syndrome, Cushing's disease, Cushing's reflex. What's Cushing's reflex? Bradycardia and hypertension associated with increased intracranial pressure. Bradycardia and hypotension with elevated increased intracranial pressure. Cushing is operating between the years 1910 and 1935. He's operating for about those 25 years. He's operating on brains with no MRI. He's operating on brains with no CAT scan. He's operating on brains and prolactin hasn't even been described yet. How does Cushing even know the tumor is there? They never heard of prolactin. If you're a guy with erectile dysfunction, you got a problem. If you're a woman who can't conceive, it's a religious disorder. However, how did he operate? Know that they were there? Headache, bradycardia, hypertension, bitemporal hemianopsia. How did Cushing know? Because he only saw the huge ones. He only knew that the really big ones were there. Bitemporal hemianopsia. Now, I'm going to tell you there's a little defect in medical education. Part of the reason that I'm making this recording with you today is to be able to reach out throughout the entire known world and protect you from your own medical schools. Why is it that in this year, at the beginning part of the 21st century, current medical students and doctors are told about bitemporal hemianopsia as the most common presentation, when it was the most common presentation 100 years ago or 80 years ago? How come you're getting your brains ruined by your own faculty? Well, if it was just you, one person, I'd say it was your problem, or just two people, or just three people. But when it's thousands of people, it's a systemic problem. We're here to correct certain defects, and that defect is this. Microadenoma is the most common, well, prolactin is the most common, and prolactinomas present with dry men and juicy women, and that's it. Bitemporal hemianopsia is more common in men because men present later. Thank you very much, and it's microadenomas. Big deal. Protect yourself from your own medical school. And that is the end of this chapter on the hypothalamus. But remember that the biggest other question is, when the pituitary stalk gets cut, only prolactin goes up, because prolactin is inhibited all the time by dopamine coming out of the hypothalamus. Why are we inhibiting prolactin all the time? Because the same way I don't put fresh food out on a table when I'm not going to eat it for 9 months. You shouldn't start lactating at your bachelorette party. You should wait until there's someone there to need the milky. So your prolactin should be inhibited until it's time for somebody to drink. Same idea. Why, if somatostatin inhibits growth hormone, why does the cutting the pituitary stalk not raise the growth hormone? Because the major stimulant to the major action on the pituitary for growth hormone is the stimulating hormone, growth hormone releasing hormone. When you lose the pituitary stalk, you lose both growth hormone releasing hormone and you lose somatostatin. What? Losing the stimulant is more important. The